Hey everyone, I'm going to wait a few minutes. If you can hear me, let me know that you can hear me. Hey Vincent, how are you? Let me know if you can hear me. Awesome. Well, I'm going to give it a few minutes, see if anyone else comes on. Um, but hopefully everyone's doing well today. This is my first one. Where are you coming from, Vincent? If it's anything like where I am, the weather's pretty crazy, getting a lot of rain, and I'm supposed to be living in a desert. I'm in Utah, so we've covered the weather. We can talk about politics while we're waiting. Chicago, huh? The weather's pretty crazy over in the Midwest too, I understand it. Yeah, I think I might just have to go ahead and get started, Vincent. That's a good question. So the topic is burden of proof. I don't really know much about how to share it, um, and that's one of those things I'll just have to learn. But it is live in the group, so I'm watching it on my computer while can't while I present from my cell phone. So. Um, and I did tag a few people. I think we'll have a few more people come on. I assume if you found it, anybody else can find it. There's Charisse. We've got two people. It's a party. Okay, we're gonna go ahead and get started because I do have a little bit of introduction stuff to get started with before I move into the burden of proof topic for today. I really appreciate those that are coming on. Obviously, if you're watching live, you're going to get the information straight up. If you're watching this in a rerun or otherwise, please go ahead and just do hashtag rerun so I know how many people watched it later on. That'll just help me kind of keep track of some stats. So really this, the group that I started is an extension of a website I created earlier this year, awittypt.com. If you haven't been there, you're more than welcome to visit. Where I have a blog where I've done a fair amount of information on authorization, utilization, utilization management, clinical review, and all kinds of things like that. But sometimes it takes a long time for those blogs to get out into the world. And it's not as interactive. Obviously, you can read it whenever you want. But I figured that Facebook Live, and even Instagram are ways that I can get that information out there. So that's where this is coming from. Today I'm presenting from my illustrious mechanical room. Got my water heater right here, got my water softener in the back, and we've got our network cables. So it's a beautiful room, beautiful view. It's a great place to talk about some of those dark secrets in skilled care. And that's one of the first things we're going to talk about today. So I also want to give a huge thanks to those that have joined the group, those that are sharing the information, and those that are inviting their friends. That's super helpful as well. I want to try and get this information to as many providers as possible, and not just physical therapists, but occupational therapists, chiropractors, acupuncture providers, speech pathologists. A lot of those, this information is going to apply to them as well. So if you have any friends that are in those areas, please reach out to them. Hey, Eric. So we've got 3 now. It's a full-on party. So tonight's topic, what I really wanted to talk about is burden of proof. I asked the question in the group. You know, I did that poll of those 3 different things and asked people what they would want to learn about. And burden of proof was kind of the top topic. And when I'm talking about burden of proof, I mean who is responsible to prove that there is a need for skilled care. You can also think of it as who is it that's showing the medical need, who's showing the information that shows that that patient needs skilled physical therapy or occupational therapy, whatever it may be. So for those that are listening, I know not very many of you are on yet, but I don't want to take too long. And I don't want to wait for too many other people to come on, just in respect for those that are here. So I do want to pose a question. Who is responsible for proving the need of skilled care? So I'm going to ask, I'm going to pause in between each one. I want you to comment. So is the doctor responsible for showing the need for skilled care? What do you think? Do you need Jeopardy music? Okay, so Vincent says the physician has to authorize for Medicare, which is correct. Any other responses? What's the doctor's responsibility? So Vincent has talked about Medicare. What about otherwise? So I'm going to open up the second question. Does the patient have any responsibility in showing a need for skilled care? Or what is the patient's responsibility? And while you're entering in your answers for that question, I'm going to give you the third one really quick. So Sharice says no, the patient has no responsibility. So what about the skilled provider? Meaning physical therapist, occupational therapist, speech language pathologist, chiropractor. What kind of responsibility do they have? Okay, and I know there's kind of a delay in getting responses, so I'll try not to take too much time in between those questions. Sharice says yes, and I totally agree. That's what we're going to talk about the rest of the time here. And it's not going to take a whole lot of time. I didn't plan on being here for a really long time today. This is really a test to kind of see how well I do with Facebook Live, and just to kind of get my feet wet with it, get you guys to know who I am a little bit, so that you know what to expect moving forward. So the reason I wanted to talk about this, for those that don't know, I do clinical review. I do it from home. I do it remotely, which means I look at a lot of clinical notes. I also look for requests from providers like you. Uh, I see the information that is faxed in from, say, your front office. Um, and that information is then uh, brought to me, and I go through the process to make determinations from there. And so I see a lot of providers saying that they have a doctor's prescription, so that means the patient therefore should get physical therapy or occupational therapy, and that's the end of it. Um, and unfortunately, this is not true. Um, even with Medicare, you need more than just a doctor's prescription. And the key to this is that in skilled care, it's all based on a functional deficit. So who is it that was trained and licensed to find that functional deficit? It was us, right? It was each one of us. If you think about how much time a patient spends with the doctor, what, maybe 10 minutes with the doctor, maybe even 15 if it's a really long visit. Is that enough time for the doctor to establish a functional deficit that needs skilled care? No, it's not. So we can't rely on the doctor's prescription to say this patient needs skilled care. And unfortunately, I get that all the time. So we have to think of it. That's right, Sharice, we're considered experts. So you have to think of it as the prescription is a recommendation. The doctor is thinking, okay, this patient needs some help. Let's send them to therapy and see what therapy thinks. So you or us, the provider, we need to find out if physical therapy is appropriate for them. And then if we disagree, we also have the responsibility to communicate with the doctor as well. So I want to use an example of a different medical field. We're going to go into pharmacy really quick, just because my wife is a pharmacist. It's kind of near and dear to my heart. But most of us have been to the pharmacy once or twice in our life at least. We get a prescription from the doctor for a medication, and then we hand that to the pharmacist, and what happens is we sit there and we wait for what seems like an eternity to get a bottle of pills. Now what's happening on the back end, what patients don't see, is that pharmacist is looking at your medical history, that pharmacist is looking for drug interactions, looking for any other problems that drug could cause based on medical history that they might have. Oftentimes, they are also contacting not only your insurance, but your doctor's office. A lot of times they will see dosage errors. They will see a medication that may interact with something else that maybe the doctor didn't even know you were on because you didn't tell them. So then the pharmacist, it is their responsibility to make sure that drug that the doctor has prescribed is okay for you. Now let's come back to physical therapy. Well, wait. I'm going to go one more place in healthcare. I'm going to go to surgery. So you go see your primary care physician because you have some kind of a major problem. Or maybe you go to the emergency department because you just broke your leg or something of that nature. Your medical problem is serious enough that physician thinks you may need surgery. So what's the next step? They send you to a surgeon for a surgical consult, right? Or maybe imaging to then get a surgical consult. It's not the physician that says you need surgery A, B, C, and D. It's the surgeon that determines that, but it was the doctor that wrote you a referral. So we need to think of physical therapy in the exact same way. If everybody's with me, if you're understanding, go ahead and give me a thumbs up on that one, or a thumbs down if you disagree. It's okay to disagree with me. Um, so now we're going to come back to physical therapy. We've kind of discussed those two other areas of healthcare, and we need to think of it the exact same way. So when we are doing physical therapy, and the doctor sends us that referral, it is our job to determine if physical therapy or occupational therapy is correct, and at what dosage and at what frequency, and what your treatment plan is going to be. If the doctor is the one determining it, then we don't need physical therapists. The doctor might as well hire some PTAs and athletic trainers and keep everything in-house. And you know what? There are doctors that do that. I'm not saying I agree with it, that's for sure. But if we want to maintain our level of professionalism and show that we have value, then we have to be the ones determining that need for skilled care. So I'm going to go ahead and I'm going to give 3 tips. So 3 tips today, real quick, and then we'll kind of just end up, and that'll be it for today. So the first one, the first tip. Sorry, I keep looking at my paper. Hopefully, I'm not making people seasick. The first tip is that you need to regularly document functional deficits of the patient in normal daily life. So we're not talking about just range of motion. We're not talking about just strength. You need to be documenting the patient's problems with things such as what percentage of work they can do, or if they're even at work. Self-care. Are they having difficulty dressing, brushing their teeth, doing their hair, eating meals, preparing meals, doing yard work, driving up and down stairs, walking, and all kinds of other things. I mean, we all went to school. We all know what those things are, and we all live a daily life. That's the information we need to get from the doctor. What I see on a daily basis is I see so many providers relying on range of motion, pain, and then sometimes strength. That's it. And I see this probably more frequently than I see providers using real functional deficits. And now take this to the insurance level, or whoever's paying for it. When they see that kind of information, what perspective of physical therapy or occupational therapy, skilled care in general, do you think they have? So unfortunately, we're being pulled down by those that are being lazy, unfortunately. And I wish there was a really good answer for that. But so number 1, make sure to document those real functional deficits. All right. So the next step, or the next tip, number 2, you must also show that that patient is significantly progressing in those functional deficits that you were recording. And by significantly improving, I mean you need to have some way to measure it that is a significant progress, and not just a blanket statement saying patient is progressing, or patient continues to progress. I see that in assessments all the time, and that's not sufficient. So this is why I recommend, hey Karen, glad you could join us. So this is why I recommend that you use functional outcome measures that are standardized. These have been peer-reviewed, they've been researched, they've been through the ringer, and there's also been established normative information sorry, I'm going to tag one person here. So, sorry, back to step number 2. So you need to show functional outcome measures that are standardized. And yes, Charisse, yeah, some of the things from providers are certainly ridiculous. Thank you so much for that comment. Hey, Will, glad to see you. We're having a huge party. There's like 3 of us. I should have brought donuts. I guess it would have only been me that was eating them. And the reason that I recommend using standardized functional outcomes is for a very important thing called MCID. Now, who remembers that from way back in school? The minimal clinically important difference. So it's the amount of progress that is required to get someone from point A to point B, and it's showing that they actually make progress, right? So those are the types of things that insurance companies are going to be looking for to see if your patients are progressing. If you don't show that significant progress in your documentation, then they're going to think that that patient isn't really progressing, or they're not progressing very much. So if you don't understand MCID, you want additional help with MCID, that's certainly something that we can focus on in the future. So if that is something you want more help with, more information on, just in the comments I know a lot of you are probably watching this on the rerun, but just go ahead and comment #MCID. Then I'll know how many people need that information, and we can do that in another live video, or I can get additional information out to you on that. So now the third step, this is the third tip, the last tip I'm going to give tonight. You need to provide care that is reasonable and necessary. I'm sure many of you know what reasonable and necessary is. It's written in Medicare, in the Medicare guidelines, chapter 15. I even have a blog post about it. If you go to awittypt.com/blog, I've actually covered it in bits and pieces in multiple of my blogs. But look for the one about medical necessity. I talk about it there too. Oh yeah, thanks for the shirt, Will. Basically, this is care that is complex and skilled enough that it can't be done at home. If any of you caught my recent just quick video to Anthony Meritato, hey Emma, thanks for coming on. We're almost done. So you'll have to go back and watch it again. You can watch how I crash and burn, but and I don't do really well when I get distracted. I'm going to have to work on that. Reasonable and necessary care is complex enough and specific enough that no one else can do it. This is what you're there for. It requires training. It requires you to follow up. It requires you to be there in the moment and using your time and your knowledge to get the patient moving along. Also, reasonable and necessary care needs to be based on research, peer-reviewed research. So clinical practice guidelines is a great one. I'm going to be getting more information out on that. I have a blog post that I have coming specifically on that and how to utilize CPGs. And reasonable and necessary is a huge topic. We'll talk about that more too, specifically with Medicare. So you can certainly do #R and N, so I know that people are interested in that as well. And we'll go over to that more in the future for sure in the group. So to review the 3, no such thing as crash and burn, huh? So those 3 tips again, you need to document the functional deficits in the documentation. You need to show that the patient is significantly progressing as they continue to come see you. Now, does that mean from every visit to every visit? Absolutely not. But within a certain period of time, and this is, again, where you also need to know some of the research. Take, for example, the lower extremity function scale, at least for our physical therapy friends. If you're an occupational therapist, you might not be as familiar with this. This one, the research behind it was done over a 4 to 6 week time period. So that's the time period that we need to be looking for progress if you're using the LEFS. Now, if you're using, let's say, box and blocks for our occupational therapist friends, or maybe grip strength, some other things, you may want to become familiar with the research and the time periods in which they complete their research, and they're looking for those differences. Okay, so that's where that's coming from. And then that third one, provide care that is reasonable and necessary, and we'll go into that more for sure. And if you can't do those three things, then you're not going to prove that your care is needed. Those are things that the doctor most certainly is not going to do. His prescription is not going to say that, and he's expecting you to do that. I think that pretty much covers those 3 tips for today for burden of proof. So if you thought that was good information on burden of proof, whether you're watching it now or later, go ahead and just give me some kind of compliment, please. Just kidding. So just to kind of finish up on this one, one of the first things I would love, again, if you did find this helpful, but you have other questions that you would like me to address, please post them in the comments. You can post as many questions as you want. I don't care. Facebook is open 24/7 days a week. 24/7 days a week. 24 hours a day, 7 days a week. So you can just keep putting your questions and your comments in there. I'll either address it right in there, or we'll plan a video for later. Other thing I'd like to ask is, please don't be afraid to ask questions just in general in the group and to get involved. I think currently we're sitting at about 112 people. Pretty good. I'm happy with that so far. And I also would love it if you share this with any students that you happen to have. One of the most unfortunate things that I have come to realize, partially from when I was a student, teaching other students and seeing students doing their clinical rotations, is that there are so many clinicians that are doing students a disservice by just getting that student to follow their patterns, which is sad. There are a lot of great providers out there, so it's certainly not everyone. But the only way that we're going to get out of this circle that we continue to be in physical therapy of not being able to prove our worth is we need to make our students better than we are or we were. And then one last thing certainly is obviously we need more people in the group that we can share this information with. There are people that are way smarter than me that I would love to have in this group that can teach me things too. I don't want to make it sound super selfish, but so please, if you just have a second, go. I sound like I'm doing a telethon all of a sudden. You don't need to pick up your phone. You don't need a credit card. But if you feel like you would like to share this group with any of your friends and invite them to the group, please do so. It would make me super happy. So thank you for those that are watching it live. I appreciate your attendance and your questions, your comments. I thought it was good information. For those that are watching on the rerun, again, go ahead and do hashtag rerun or replay or whatever. So then I kind of have a better understanding of who's watching it and any questions you might have. So that's it for tonight. I hope you enjoyed it. I appreciate each and every one of you. Thank you so much, and we'll catch you on the next one. See ya.